Well, I want to really thank the program committee for having me speak at this conference. I was here a few years ago, and you're a great group. And frankly, when I come from Toronto, I really enjoy the change in weather. It's beautiful here, as you all appreciate. What's also impressive is every meeting I go to now, there's a lot of discussion around Stop the Bleed. And I know you had a very inspirational talk yesterday, and I'm sure as a result of that talk, you have all sorts of great ideas about how to roll that out. But that is going to have tremendous impact around the country. So what I wanted to speak about is how we use TQIP data to look at practice-changing protocols and paradigms. And you might be familiar with the NASM report. This is the National Academy of Sciences, Engineering and Medicine, which came out with a report in about June 2016 with the aspirational goal of reaching 0 preventable deaths and reducing trauma-related disability. But the focus primarily is deaths. And as a result of that document, there's 11 recommendations. And the recommendations really speak to better integration with the military and civilian trauma systems, and also using data in a very smart way, a way in which we can use the data that we have to make the best available decisions. And in essence, that's called focused empiricism. And you see a quote there from the Surgeon General in 1921, Dr. Merritt Ireland: "War is a very efficient schoolmaster," which means you have no choice but to learn quickly because the stakes are high. You have to adapt what you do, modify your practices to save lives. And while it says the military health system can't rely on clinical trials, either can we. It takes typically 5 to 10 years to develop a trial, execute a trial, analyze the data, and then many years to change practice. We really don't have that time available if you want to achieve 0 preventable deaths. And there needs to be a culture of continuous performance improvement where we take the available data and we make changes based on that data. It's kind of like PI on the fly. And that's required, again, if you want to make a difference quickly. If you want to wait 5 or 10 years for a trial, there are some things that will need to have a trial because we'll never have a good answer and the risks of a particular approach are too high. But for the most part, we're looking at subtle differences in outcome that can be evaluated using large data sets. And this is what I'm going to speak to you about today. So how do we make the best of observational data? So we have lots of TQIP data. We have about 700 hospitals now and hundreds of thousands of patients. And using that data, you really can explore how one hospital differs from another hospital and how that might influence outcome. And we've looked at this with respect to hemorrhage control, preventing DVTs and PEs, how to manage severe TBI, managing orthopedic injuries, end-of-life care, and a little bit about trauma systems, which I'll speak to at the end. So we start with valid and reliable data. And we provide reports back to centers. And most of you are familiar with that piece if you're involved with TQIP. We try to identify what the high-performing centers are doing right, and we do that through our symposia and abstracts and publications. We feed back the data to centers, and then they continue to improve. But behind the scenes, we actually look at the data. We look at the data closely and say, okay, this is an important research question. There's a bunch of hospitals doing this. There's a bunch of hospitals doing that. Well, which is the right thing to do? And I'll highlight a number of studies that have focused on that approach. So the first first case actually begins with a 70-year-old female husband, instead of putting the car in reverse, puts the car in forward and crushes his wife. Lots of bruising over her lower abdomen. She's hypotensive, a little tachycardic. Chest x-ray is normal, FAST is negative, and this is her pelvic x-ray. So a nasty pelvic fracture. So the pelvis is wrapped, blood transfusions begin because she's hovering in the 80s blood pressure, and now we're considering our options. And this is not an uncommon scenario. If you have Reboa, you might consider Reboa, although she's kind of responding to transfusions. Do we go with preperitoneal packing? Ideally, we would just go with angioembolization, but we know that angioembolization takes time. And my fellow refers to this as an opportunistic CT scan, although she probably needs angioembolization urgently because the angio is not in-house and the CT is available. We'll get an opportunistic CT just because it's available. Not great for patients, but that's what we end up doing. So we wait. We end up waiting and transfusing, and that's, again, not an uncommon scenario. So how long do we typically wait? Well, we looked at this in TQIP, and we asked a number of questions. What are the predictors to time to angiography? What hospitals can get angio done quickly? Which hospitals not so quickly? How does this impact on mortality? And can we figure out what the optimal response time is? And you'll see what the optimal response time is in the orange book, and you'll see how different it is than reality. So we looked at almost 1,400 patients at almost 250 hospitals over 3 years. And the first thing is this is actually a pretty rare event. The highest volume center had about 16 patients per year, so 48 patients over 3 years. This is not common. The typical center has about 1 to 2 patients a year. Most of these occur off hours, and these are sick patients with a high mortality and lots of other injuries. No surprise there. So 20% of these patients underwent surgical hemorrhage control first, which is typically a laparotomy, followed by pelvic angioembolization. And what's amazing here is the median time to angiography among those patients who went straight to angiography, had no laparotomy or anything else, was 3 hours. So 3 hours to achieve hemorrhage control. Is that surprising? I think so. When I look at our data for surgical hemorrhage control, we're typically looking at about an hour from ED arrival to OR. Here it's 3 hours for pelvic angio. 1% are within 30 minutes. So we're taking 3 hours to get hemorrhage control. That's problematic. If you look at the predictors of time to angiography, obviously off hours takes longer, up 20 minutes longer. High volume centers somehow have figured out how to mobilize their angio team and can respond quicker. And non-teaching hospitals also, for some reason, have the ability to mobilize resources more quickly. Maybe there's less time required for the workup by residents and fellows before the angio is ultimately done, but non-teaching hospitals are quicker as well. But this is the important thing. There's actually no one time that's better than another. There's no threshold saying if you get it done within an hour, you're going to save more lives than 2 hours. The longer it takes to get angio done and stop the bleeding, which is no surprise, the higher the mortality. Okay, so the sooner you can get it done, the better it is. So this is interesting because when you look at the standards in the Orange Book, the standards say you have to have interventional radiology available in 30 minutes. Okay, well, I think we need to be more prescriptive with that standard. We need to say something like there's an expectation from time of consultation to needle and groin is 1 hour or 1.5 hours or something. We have to get that 3 hours down. And again, we have to touch base with those centers that have figured it out to try to reduce the time to angiography to save more lives. So that's an example in hemorrhage control. But let's look at a much more common scenario. So there's lots of patients like this, 68-year-old male, otherwise healthy, one of those few elderly people who aren't on anticoagulants, trips and falls, transient LOC, amnestic to the event, has a normal exam with no lateralizing signs, and that's a CT scan, traumatic subarachnoid hemorrhage. Okay, so we see lots of patients like this. Who would admit this patient to an ICU? Just a show of hands. So some do, some don't. Many are not committing. So we looked at this with a large meta-analysis, and this meta-analysis was just published last month, but looking at 13 studies, 15,000 patients. This isn't TQIP data, this is other data. And the probability of needing neurosurgical intervention was 2 per 100,000 patients. So very low probability of something bad happening requiring an operation. A small percentage had neurologic deterioration, and there was 1 death of 15,000 patients due to brain injury. Okay, so lots of patients with this problem. And for the most part, it's not all that morbid. Well, what happens in TQIP? So we looked at 14,000 patients in TQIP, average age of 70, most were same-level falls, 16% were anticoagulated, and this is focusing on patients with mild TBI, so GCS in the 13 to 15 range. So what happens in TQIP? Who's being put in an ICU environment with this particular problem? So only 30% of patients are admitted from the ED to the ward. 70% end up in an ICU. And you'll see on your far right represents those hospitals where almost all of their patients end up in an ICU. And on the far left, there's a bunch of centers that there's far fewer patients being sent to an ICU. So lots of variability in terms of who's using their ICU resources wisely. And you might want to think about this in terms of reducing your ICU utilization. These patients probably don't need ICUs in most cases. So there were neurosurgical interventions in 34 patients. That's 0.2%. The meta-analysis was 0.002%. So it's not zero. Survival was very good. Length of stay was 2 days, and length of in the ICU, and length of stay overall in the hospital was longer if you were admitted to an ICU first, probably because of the transfers and so on that take more time. Just based on random chance alone, there was a 4-fold difference in using an ICU bed if you were admitted to one random hospital over another random hospital. So this is where you might want to consider a choosing wisely initiative around reducing ICU utilization for certain types of patients. They probably don't merit the ICU in most scenarios. What about severe TBI? So these are higher stakes population. 62-year-old male, fell off an embankment, GCS6 in the ED, so just withdrawing. No lateralizing signs. He's intubated, goes to the scanner. Again, we see this not infrequently. And bad hemorrhagic contusions. Okay, so who would put an ICP monitor in this patient? So some hands. In TQIP, probably about 25% of patients like this get an ICP monitor, much lower than you'd expect. We've looked at the relationship between putting an ICP monitor and mortality in TQIP. And what you see on your left shows that centers that have higher ICP monitor use have lower rates of mortality in patients with severe TBI. And the same holds true in pediatric patients. So the more ICP monitors that you place in your center, the lower the mortality. And you can argue, okay, maybe putting an ICP monitor means the neurosurgeons actually care and they really want to be involved and want to be very aggressive with these patients. Well, the first point is that putting the ICP monitor in alone, that alone only accounts for 10% of the variation in mortality. So there's something else going on apart from just putting the device in. So one of the things is, again, maybe it's the neurosurgeons are just more engaged. We looked at the relationship between what the trauma medical directors thought about neurosurgical engagement and ICP monitoring practices. We did a survey asking the TMDs, are your neurosurgeons engaged on a scale of 0 to 100? And there was no relationship. So there were centers that had high rates of ICP monitoring and disengaged neurosurgeons and vice versa. There was no relationship between neurosurgical engagement and using ICP monitors. What did matter, though, is if you had protocols to identify patients with high ICP, you had protocols to identify who should be getting an ICP monitor and what you should do with high ICPs, then you're more likely to use ICP monitors. So it wasn't based on neurosurgical input. It was based on coming up with a standardized protocol to identify the right patients, get an ICP monitor in the right patients, and then manage ICP appropriately. So it was really coordination of care more than the individual per se. Now, there's other aspects about this patient population that are problematic. One is there are lots of patients who come in with low GCS, and they look like their outcomes are going to be very poor, and there are discussions about withdrawal of life-sustaining care. This is not an uncommon scenario in people with severe TBI, particularly in elderly patients. This is the proportion of patients who die with withdrawal of life-sustaining care. So probably about half of all patients with a TBI, similar for elderly, have a withdrawal of life-sustaining order before they die. So there's a deliberate decision to withdraw care. And what we've been hearing is that many centers don't want to withdraw care because it makes their TQIP report look bad. And we've tried to emphasize that it's important to focus on the needs of patients and their families, not necessarily what the TQIP report would look like. And this varies a lot. So if you look at this across all hospitals in TQIP, there are centers that never withdraw care, those that never surrender, and those that always withdraw care. So those that withdraw care a lot are worried that the TQIP report is going to look bad. So we actually looked at centers that tend to withdraw care early versus those that withdraw care late. And we said, okay, is there a difference in their mortality if you withdraw earlier, not giving the patient a chance to get better perhaps, versus withdrawing late? And you can see here that the centers that withdrew early weren't all that much different than those that withdrew late. Same number of severe TBI patients per year, similarly aggressive with ICP monitors and rates of craniotomy, and mortality, crude mortality was the same. And we looked at adjusted mortality. There was absolutely no difference. Patients cared for in early withdrawing centers had no higher rates of mortality than patients cared for in more quick withdrawing centers. What this means basically is do what's right for the patient. Don't worry about your TQIP report. Although that makes perfect sense as a statement, I can tell you that what we're seeing is a lot of concerns around aggressive palliative care practices, but do what's right for the patient. What about tracheostomy? So this is a challenging trial to do, the timing of tracheostomy in patients with severe TBI. There's very, very strong biases about whether early trachs make a difference. And there have been attempted trials which have been abandoned because of such strong beliefs. So about 30% of patients with isolated TBI undergo tracheostomy, and 40% of these tracheostomies are done within 7 days. So should they be done early? Should they be done late? Difficult question. Again, this varies across all centers. So you can see the median days to tracheostomy on the y-axis here. And there were a bunch of centers on the far left that do trachs early, and a bunch of centers on the far right that tend to do them around 2 weeks. So a lot of centers actually do them at 7 days or 2 weeks. That's pretty typical. Well, we compared centers that go ahead and do trachs early versus those that do trachs late. And the centers that do trachs early have lower rates of pneumonia, fewer ventilator days, shorter ICU length of stay, and a shorter hospital length of stay. So I know there's still strong believers that there's no rush to tracheostomy. My personal feeling is they make a difference if done early. And my hope is that some of these data get out, because I think that randomized control trial is going to be very challenging to do. I know we have one in a number of centers in Canada, and I think there's been 5 patients enrolled over a year because people have such strong beliefs around this. Okay, well, what about DVT prophylaxis in a patient like this? So challenging, because the neurosurgeon says any blood in the brain, don't start DVT prophylaxis. Many of the trauma medical directors, trauma surgeons want to start early, intensivists want to start early, neurosurgeon says stop. So what's the practice? If you look at the timing of DVT prophylaxis, this is when we start the drug for DVT prophylaxis. For patients with blunt multisystem injury, most of the time we're starting around 2 or 3 days. Okay, these are patients typically without bad brain injuries, and they get prophylaxis starting early. And I think there's a lot of consensus around 2 to 3 days. Look at patients with severe TBI. It's all over the map. No one knows when to start DVT prophylaxis in this patient population. And there are many patients who start beyond 7 days and some who never get any VT prophylaxis. So can we answer this question with TQIP data? So we did a study looking at patients who have the drug started early versus late. And you can see here that the rates of DVT and PE are lower among those patients who VT prophylaxis started earlier. So 50% lower rate of PE and about 50% lower rate of DVT. And there is no higher risk of late problems like having a delayed craniotomy for bleeding, late placement of an ICP monitor, and no difference in mortality. So those patients who receive early prophylaxis don't tend to have worse outcomes than patients who receive late prophylaxis, defined as 72 hours. Also, when we look at hospitals' practices, we're able to say that these hospitals start early and these hospitals start late. And is there a difference in the PE rate among those centers that start early versus late? And there's actually a nice stepwise cause and effect. So centers that start early, 6% rate of VTE. Centers that start late, 8.6% rate of VTE. So if you have a VTE problem in your center, you might want to consider when you're starting the drug in your patients. Okay, so again, a difficult randomized controlled trial to do because everyone has such strong beliefs about this, but there's some evidence that it's safe. And there's actually criteria that you can use to help focus your attention on the right type of patient who might benefit from early prophylaxis. So most patients, this is the Byrne-Norbert criteria published in 2012. So most patients probably fall into the lower moderate risk criteria. And in essence, that means that if their repeat CT scan at 72 hours is okay, you can start VT prophylaxis. That's probably true for most patients. Okay, so an opportunity to change your practice there. What about the drug that you use? Should you be using low molecular weight heparin or unfractionated heparin? So the evidence is actually, I think, pretty good for low molecular weight heparin, but there's still many hospitals that haven't switched their practices. In TQIP, about 74% of patients receive low molecular weight heparin and about 25% receive other. The PE rate overall is about 1.8%. And when you compare low molecular weight heparin versus unfractionated heparin, low molecular weight heparin is a better drug. It is more effective at reducing PE in all types of patients. You know, as high as 44% lower risk of PE among all patients. It's as good in patients with shock as those with severe TBI or orthopedic injury, probably the most effective there. So if you're using unfractionated heparin, you might want to consider a change if you have problems with your PE rates. And again, same sort of thing. We said, okay, centers that typically use low molecular weight heparin, do they have better outcomes than centers that use unfractionated heparin? Well, the more low molecular weight heparin you use in your patients, the lower the rate of PE. Again, a stepwise effect here, from 2% all the way down to 1.2% rate of PE for those centers that use a lot of low molecular weight heparin. Okay, so some challenging orthopedic issues that we've tried to evaluate using TQIP data. What you see here is a mid-shaft femur fracture and a nasty open tibia fracture. So the optimal timing of femur fracture fixation, I think is pretty clear in the literature. It should be done within 24 hours unless you can't do it for some other reason, bad head injury, patients not yet resuscitated, or so on. Most patients should have their femurs fixed within 24 hours. So we looked at almost 20,000 patients across TQIP with mid-shaft femur fractures. The median time to fixation was 14 hours. So they were being fixed promptly for the most part. But we compared patients who were fixed early versus fixed late. And we matched them on all sorts of characteristics. We matched them on age, on comorbidities, on mechanism of injury, the severities of other organ injuries they had, what they looked like when they came in with shock, GCS, and so on. And we also controlled for whether they had an early other surgical intervention like a laparotomy or craniotomy. And so we actually took care of the fact that some patients might have delayed fixation because they were sicker. And there is no question that those patients who have their femurs fixed early, this is midshaft femur fractures, have better outcomes. Lower rates of PE and lower risk of DVT, less acute lung injury, less pneumonia, shorter length of stay, and no change in mortality. So there's probably about 25% of patients who are fixed late, and there are hospitals that tend to fix their patients later, and I think it might be because they don't have the right resources, they don't have available of an OR, there's some problem that doesn't allow them to get their patients to the OR quickly enough to have their femurs fixed. Really very few patients wait from benefiting from an operation. And we compare it again, centers that fix early versus those late after adjusting for all the differences, and centers that fix early have, again, lower rates of PE. So again, it's a pretty consistent finding. If you do the right thing early, better outcomes. What about these open tibia fractures? So there's not a lot of these patients with bad open tibias that require sort of combined orthopedic and plastic surgical approaches for definitive skeletal repair and ultimate coverage. The Orthopedic Trauma Association and our TQIP best practices says that if you have a patient like this, you really need to get soft tissue coverage within 7 days. I know in my own hospital, I can't get the plastic surgeons and the orthopedic surgeons to the OR at the same time. So things get delayed, and orthopedics keeps bringing the patients to the OR for an I&D, and finally plastic shows up and ultimately does a flap, and they cover the wound. The recommendations are soft tissue coverage within 7 days. So how important is that? So this is TQIP data. So 40% of patients with open tibia fractures have their flaps done within 7 days. 60% don't. So a big opportunity for improvement. And those that don't, if you look at the y-axis here, there's a much higher rate of deep infection, osteomyelitis, or amputation. So important to get these patients covered early so that they don't have these adverse outcomes. And we're probably underestimating osteomyelitis because a lot of patients get it post-discharge. If you look at this from a different perspective, this shows the rates of bad outcomes if you're covered early versus late. Osteomyelitis rates are higher, deep infection rates, amputation rates, any of the above. So for every one patient, for every 10 patients we treat late, we don't do the right thing, one suffers harm. And the average center might see three or four patients a year like this. There's no way that you're going to recognize that you're causing harm in these patients. There's just too few patients in an individual center. But you look at the data like this, you get a sense that you could be harming patients if you can't get your plastic surgeons and orthopedic surgeons together to manage these patients. My last area of focus is trauma systems. And this, for the most part, isn't TQIP data, although we're trying to work in TQIP data, some of these data into TQIP. Really, it speaks to EMS performance and how EMS functions in your region. And there's no value to a trauma center if you can't get to the right place at the right time. I mean, that's pretty clear. This is good data from quite some time ago, showing the differences in motor vehicle crash mortality based on population density. So the map on your left shows population density, the map on your right shows the motor vehicle crash mortality rate. So the most population-sparse regions of the country have the highest rates of MVC. Okay, so if you compare Esmeralda, Nevada to Manhattan, for example, the least population and the most population dense, the rates of MVC mortality are much, much higher in Nevada than in Manhattan. Okay, just based on a population count perspective. So lots of factors come into this. There's challenges with getting patients to definitive care. There's different types of roads, different types of cars, a variety of things. We decided we were going to focus on EMS response times. So EMS response times are those times between the 911 phone call and EMS showing up at the scene. And we asked the question, do counties with shorter EMS times have lower rates of motor vehicle crash mortality? So how important is that factor alone at reducing your county MVC mortality rate? We looked at MVCs over a 3-year period, 13 to 15, and we used data from NEMSIS. So NEMSIS is like the National Trauma Data Bank, but for EMS. Many of you might know about it, but all of the EMS data gets into NEMSIS, and we use that to get the EMS response times. and we use FARS. So FARS is the Fatality Analysis Reporting System. It's actually a wonderful database, but it has every single motor vehicle crash that results in a death on a public road in the United States. So we're able to know what response times are for certain counties and what their crash rates are in different counties. Allows us to connect the dots. So these are county EMS response times. This is almost 2,300 counties. We don't have data on every county, but you can see that the typical county response time is between 8 and 9 minutes. Again, that's the time between 911 phone call and EMS response at the scene. There's some that are far out on the right. These are probably very, very rural areas, and a few where there's very quick response times, probably in urban areas. So big differences in response times across the country by county. And this is it in a graphical format. And you can see that the darker the color, the darker the green, the faster the EMS response time. And you can look at Arizona there. So there's some counties in Arizona that have very quick response times, and obviously some with very long response times. They're lighter in color. And there's a few counties where we have no data. So this basically shows you EMS response times across the country. And when we look at EMS response times and MVC mortality rates, what you see here is a nice continuous relationship. The longer it takes for EMS to respond to a call, the higher the probability of a motor vehicle crash resulting in a death. Okay, and this is after you take into account differences in the patient populations across counties, the fact that some counties are more rural than others, traffic safety laws, and a whole variety of other things. Okay, and the threshold seems to be around 8 minutes. So counties with longer than 8 minutes response time have a higher rate of death. We also looked at the proportion of patients who die before they arrive to hospital. So in FARS, we actually know when people die. Do they die in the field? Do they die in hospital? And if you look at this, if you look at the y-axis here, it's the odds of pre-hospital death. So how likely are you going to die before you get to hospital? You're more likely to die in the field if your EMS takes longer to respond. That's no surprise, but it's actually kind of cool having a number. 8 to 9 minutes seems to be the threshold that's going to make a difference. It doesn't take long to die when you don't have an airway or when you're bleeding. And these are probably these as the first responders are going to have that impact on whether or not you actually make it to hospital or not. If you don't make it to hospital, you're not going to survive. If you make it to hospital, at least there's a probability that you're going to survive. So is reducing EMS response times cost effective? So if our goal is to get to 0 preventable deaths, should we resource all those rural counties so they can respond in 8 minutes? And I think that that would be extremely challenging, expensive, and from a cost-effectiveness standpoint, probably not make a lot of sense. So, this data is out there. It will be out there soon. But if we want to achieve 0 preventable deaths, we have to put a lot of money into this, and I think it's going to be quite a challenge, particularly in rural America. So I think with these data, I've given you a sense of opportunities that come to us through TQIP data, where we explore variations in practice. We're not sure of a particular approach to care of a type of patient. We look at who's doing what, and we compare these variations in practice and say, okay, these variations or this particular practice is associated with a better outcome. Maybe we should all move in that direction. And we have a lot of other questions that we can ask of the data. This is just a starting point. But I think what's the most important, and if you're getting involved with TQIP, if you think you're doing something special in your center, please let us know. There's no way of us knowing that and bringing it to others, and there's no way of even asking the question. So the soft tissue coverage came up as a result of a question that a few trauma centers had. We looked at the data, we looked at our own data, and we made a recommendation around that. This is how we get best practices back to you. So if you think you're doing something special, let's look at it, let's see who else is doing it, and let's see if it really makes a difference. And with that, I'm happy to answer questions.